Thank you all for being here. I'm Alisha, and today I'll be taking you through our work, which looks at how risk behaviors cluster over time and why this matters in the context of disease. So, the starting point of our work was this issue of multimorbidity, which is when a person has two or more chronic conditions at the same time. It's a growing challenge for healthcare globally, but it's particularly problematic in aging societies like the UK, where its prevalence is already concerningly high and is only expected to rise with time. As a condition, it's exceedingly costly, both to the healthcare system and the individuals involved. And more problematically, it's highly inequitable. People living in more deprived areas tend to get it 10 to 15 years earlier than their counterparts living in more affluent areas. And trends in England suggest that not only is multimorbidity more common in recent cohorts, it also seems to be emerging early in the life course. So, as you can see in the top two graphs shown here, they show the age specific prevalence of multimorbidity across the recent 15 years. And as you can see, the rates have been steadily rising over time across all age groups. And a similar but slightly more subdued trend is also seen for complex multimorbidity, which is when a person has chronic conditions that affect three or more body systems, like the respiratory system, circulatory system, and other such systems. Now, we know that chronic conditions result from a number of interacting risk factors, which could be biological, social, behavioral, which are, for this reason, hard to isolate and target. Fortunately, most conditions that lead the burden of multimorbidity tend to be preventable, or at least their onset can be delayed. And so we approach this issue of multimorbidity through the lens of prevention. And so we focused on the most modifiable of risk factors, which were these behavioral risk factors. More specifically, we focused on four risk behaviors: smoking, poor nutrition, alcohol consumption, and physical inactivity. And for the rest of the presentation, I will be referring to these as SNAP behaviors. Now, what we know about SNAP behaviors is that they evolve over time. They change across the life course as we go through multiple life transitions. We also know that risk behaviors tend to cluster. And what I mean by that is certain combinations of these behaviors tend to occur more frequently in certain subpopulations. For instance, the combination of heavy drinking and smoking occurs far more commonly in men than in women. Similarly, clusters with the highest number of risky behaviors are found to be associated with lower socioeconomic levels. But the reason this cluster of the reason this notion of clustering matters in the context of disease is because some combinations tend to have compounding health effects. For instance, in the case of oral cancer, a person who both smokes as well as drinks, their risk is several times over what you would expect by simply adding up the effects of these individual risk behaviors. But what we found is that most epidemiological studies, when it came to examining these risk behaviors, tend to use a measure called the cumulative lifestyle index, where you simply add up the number of risky behaviors a person is engaging in. And the limitation with using such a measure is A, it doesn't tell you which behaviors or which combinations of behaviors are driving the risk. And B, it also treats behaviors as substitutable. So, for instance, if I both smoke and drink heavily, and there is another individual who smokes and is physically inactive, in essence, these are very unique risk profiles with, again, distinct health effects. But if when you use a measure like this, you can see where the problems with that would arise. And so some studies have gone a step further and they have tried to examine specific combinations of these behaviors using diodes, triads, tetrads. But the issue with these studies tends to show up in the results section because the riskiest combinations tend to be rare. And because of sparse data, they tend to be eliminated from further analysis. And so we wanted to find a way to be able to examine multiple risk behaviors simultaneously over time and see how that was associated with disease. Now, some studies have examined these clusters of multiple risk behaviors, but they have mostly focused on younger age groups and predominantly using cross-sectional data. So you don't get information on trends over time. And to date, at least to the best of our knowledge, no study has examined how risk behavior clusters over time are associated with multimorbidity. So the overarching question we wanted to examine was how do health risk behaviors cluster over time in older adults, and how are these clusters associated with multimorbidity? So to do this, we use data from the English Longitudinal Study of Aging, which is a longitudinal data set of older adults aged 50 and over living in England. Our sample included 4,759 individuals who had participated across all 6 waves of data collection that are shown here. And this slide, as you can see, also shows from which waves we collected information on which variables. So we broke down our aim into three objectives. Our first objective was to examine how do SNAP behaviors cluster over time in older adults. Our second objective was to examine how does membership in different behavioral clusters vary by sociodemographic characteristics at the baseline wave. And finally, we wanted to examine which, if any, behavioral clusters were prospectively associated with multimorbidity. So to identify the clusters, we used a method called repeated measures latent class analysis. This is also called a finite mixture model because its central assumption is that the population is made up of a mixture of a finite number of subgroups where each subgroup is considered to have a similar response pattern, or in our case, a similar behavioral profile. And I like to think that this is a more intuitive way of understanding these methods. So we had a sample and we used information on these 4 risk behaviors collected over a span of 10 years or 5 waves of data collection to essentially identify information on 3 things. The first was to identify how many clusters best represent our data. The second was to identify what was the size of each of these clusters. And finally, we wanted to know what was the behavioral profile of each cluster that was identified. For our second step, we wanted to examine how sociodemographic characteristics listed here at the baseline wave were associated with cluster membership. And for this, we used multinomial logistic regression. And finally, we wanted to examine how cluster membership was associated with disease. So to do this, we used a separate binomial logistic regression model for each of these health outcomes. And we also adjusted for that specific health outcome at baseline. And here I should also mention that we did not include information, or we did not further analyze information on nervous disorders and mental and behavioral disorders on account of a very high proportion of missing data. I think it was over 88% or 90%. And here are our results. So we found that 7 clusters best represented our data. If you look to the right-hand side of the screen, you will see the 4 behaviors and levels of engagement in them are listed. And to keep things simple, lighter shades stand for less risky behaviors, darker shades stand for riskier behaviors. The x-axis shows the health behaviors across waves of data collection, and the y-axis shows the probability of engaging in a given behavior at a given level. So I'll take you through these clusters one by one. If we start with the cluster on the top left corner, we label this cluster low risk because individuals in this cluster had a low probability of engaging in any behavior at a risky level. We label the second cluster low risk yet inactive because physical inactivity was the only risky behavior that characterized this cluster. And similarly, for the third cluster, we labeled them low risk yet heavy drinkers because heavy drinking was the only risky behavior in this cluster. For the fourth cluster, we labeled them abstainer yet inactive. This was the only cluster which abstained from both alcohol and alcohol consumption and smoking. And the only risky behavior that characterized them was physical inactivity or low levels of physical activity. The fifth cluster, as the name suggests, poor diet, and they were physically inactive, and they also did not consume the recommended levels of fruit and vegetables per day. For the sixth cluster, we labeled them inactive heavy drinkers. Again, as the name suggests, they were physically inactive and they drank heavily. And our final, but our smallest, and I would argue our riskiest cluster was labeled high-risk smokers because this was the only cluster that had a very high probability of smoking. And this was also the only cluster that was characterized by engaging in 3 risky behaviors. Now, I also want to draw your attention to the trends over time. So on the whole, we found that these trends were fairly stable over time, but there were some exceptions. So for instance, in the case of high-risk smokers, you can see that the proportion of current smokers tends to fall quite steeply over time. And similarly, we found that for the clusters that were characterized by either complete abstinence from alcohol or low alcohol consumption, that there was a gradual increase in the proportion of abstainers over time. So this, you can see this trend in the low risk cluster, the abstainer yet inactive cluster, even the low risk yet inactive cluster. Now, these are the results for the associations between the sociodemographic characteristics and clusters. I will take you through a broad overview of these results in the next slide. But before I do that, I just want to mention that because these results were taken from a multinomial logistic regression, all the numbers that you see highlighted in bold are significant odds ratios. And because odds ratios are always relative to a certain group, in our case, we took the low risk cluster to be the reference group for all of these results. So this is a broad overview. We found that the two clusters of heavy drinkers were predominantly male, and this pattern is consistent with what you find more generally in the UK. We found that the abstainer but inactive cluster comprised mostly women. The low risk yet heavy drinkers were more likely to hold intermediate and professional and managerial jobs compared to the low risk cluster. But even on the whole, they were most likely to hold intermediate and professional managerial jobs. And finally, the five clusters that were characterized by physical inactivity tended to belong to lower tiers of wealth and tended to also be less well educated. We also found some differences in between the clusters when it came to health outcomes, and some results were more predictable than others. For instance, in the case of respiratory disorders, as you see, the high risk smokers had a significantly higher prevalence for respiratory disorders compared to all other clusters. We also found differences in the prevalence for multimorbidity, and the black lines shown here, they show the significant pairwise differences between the clusters. So here you can see the abstainers but inactive cluster and the low risk yet inactive cluster had a significantly higher prevalence compared to some of the other clusters, especially the low risk cluster. We also found differences in the prevalence of complex multimorbidity. I won't take you through all of these pairwise differences individually, but on the whole, you can observe that the abstainers but inactive cluster and the low risk yet inactive cluster, just like the results for multimorbidity, for complex multimorbidity as well, they had a significantly higher prevalence. And finally, we also found differences in endocrine, nutritional, and metabolic disorders. For our study, this comprised mostly diabetes and diabetic eye disease. And here again, you see a similar trend. The abstainers but inactive cluster and the low risk yet inactive cluster had a significantly higher prevalence, although we also see that the high risk smokers had a slightly higher prevalence as well. So just a quick recap of the health outcomes. We found predictably that high risk smokers were most likely to have respiratory disorders. Low risk and low risk yet heavy drinkers had a lower prevalence of all health conditions studied. And the abstainer but inactive cluster had the highest prevalence of multimorbidity, complex multimorbidity, and endocrine disorders. I'd like to pause here for a second just to highlight that this cluster, the abstainer but inactive cluster, a cluster that was characterized by only one risky behavior, had worse health outcomes for a number of diseases as compared to some of the other clusters that engaged in two or even three risky behaviors. And when it came to explaining these results, we had a few discussions, and I suggested, could it be the case that because this cluster could the socio-demographic characteristics of this cluster, that it was primarily female, 70% female, was less well educated, less wealthy, could that have something to do with the results? But in our study, we couldn't make that case because when it came to assessing the associations between the clusters and the health outcomes, we had already adjusted for these socio-demographic characteristics. This is just a summary of all of the findings. And finally, and I would argue most importantly, we come to why is this useful? So we found that the health risk behaviors tended to be fairly stable as people age, and so we recommended that they ought to be addressed early. The stability of the health behaviors over time could be on account of the population we chose, which were older adults, in which case the risk behaviors tend to reflect lifelong habits, which again tend to be fairly ingrained. So it's completely plausible that if we were to look at younger populations or a population which is more representative of a wider age group, these differences could be stark, and it could be interesting to look at how those differences translate to associations with disease. Examining clusters of multiple risk behaviors in this way can also help us identify high-risk subgroups, and this information can then be used to develop targeted interventions that can be tailored to the specific behavioral profiles and socio-demographic characteristics of the identified high-risk subgroups. And finally, and what I find to be most interesting is that we found a complex relationship between risky behaviors and disease outcomes. And this contradicted some previous work, which had found linear dose response relationship between behaviors and outcomes, which is just another way of saying they found that the higher the number of risky behaviors you engage in, the worse the health outcomes. But in our case, we found that the cluster that was characterized by only one risky behavior had far worse health outcomes than some of the other clusters with a higher number of risky behaviors. And one way to potentially uncover the mechanisms at play or what are the relative contributions of these behavioral factors, or maybe some other factors we didn't consider, could be to look at interactions and see what is the relative contribution of these. And ultimately, the value of this work will only become clear as these methods get replicated in other populations, perhaps populations in other countries and populations with a wider age range, because not only can we expect the distribution of health behaviors to be different in different populations, but also the link between those behavior clusters and disease to be different. And another thing I should mention is, because of the nature of the methods that we use, latent class analysis, which is essentially a person-centered approach, a sort of unsupervised learning where you try to extract patterns from a given population, it makes it very hard to make generalizations to other populations. So to derive much value from it or further value from it, uh, it would be useful to understand how these clusters emerge in other populations. And before I end this presentation, I would also like to share that we have replicated these methods using the Understanding Society dataset, which is a representative dataset for the UK population and considers a wider age range. But I will not be able to comment on those results because they just came in just 2 nights ago. And with that, I would like to end this presentation. Happy to take any questions you may have. Thank you.